Hello, everyone. I would like to welcome you to this month's round. I'm Sama Atiye, and I will be the moderator of today's session. I would like to thank everyone who have joined us remotely today. Today, we will hear from our speaker, Professor Carmen Loisel, and after which we will open up the floor to discussion and any questions you might have. Professor Carmen Loisel holds a PhD in nursing and psychology, double major, from the University of Wisconsin-Madison, USA. She's a full professor in the McGill Faculty of Medicine and Health Sciences, jointly appointed in the Department of Oncology and the Ingram School of Nursing. Dr. Loisel holds the Christine and Herschel Victor Hope and Cope Research Chair in Psychosocial Oncology, and she is a board member of the Canadian Academy of Health Sciences. Her research focuses on the development, testing, and implementation of innovative interventions, including digital health, with a co-design approach to best support individuals affected by cancer. Dr. Loisel is the president of the Canadian Association of Psychosocial Oncology, and she will be presenting today on how CAPO is leading the way toward a national patient advocacy agenda. Dr. Loisel, we are delighted to have you, and the floor is yours.
Thank you very much, Samar, for this introduction, and thank you, the Canadian Cancer Survivorship Consortium, for inviting me. I would also like to acknowledge CAPO as a wonderful organization that I've had the honor of being president. And also I'd like to acknowledge CAPO Advocacy Committee that has been continuously providing input into this work. And last, the doctoral candidate that you just heard, Samara Atiye, has been really diligently working on this initiative that I'll present today. So it's a real great teamwork that I will be presenting. So just as, let me just see, yes. So like many organizations, during COVID, we have undertook a strategic plan, and we have revised how the organization, the Canadian Association of Psychosocial Oncology, how the vision and the mission really responds to the need of people affected by cancer. So you can read here the vision that is really to optimize health and healing. And I can't underscore enough how important words are. So we chose to say optimizes because when we say improve, we assume that people need improvement. Optimizes mean that we just want to make sure that there's value added to what people are experiencing in terms of support. So that's the vision, that really we do optimize health and healing for every Canadian affected by cancer. The other word here, affected by cancer, means that we're not just talking about people diagnosed with cancer, but anyone that's affected by cancer. So caregivers, family members, friends. And again, we're talking about people affected by cancer. We're really trying to remove the words cancer patients, colorectal cancer patients, breast cancer patient, because we've heard over and over that individuals affected by cancer do not like to be called by their cancer. So there's a call and maybe some advocacy around being really cautious in terms of the words that we use, so that we feel, and people that are affected by cancer feel that they're being included and their voice is being heard. So in terms of mission, we have really 4 pillars, and one is innovation and education. Second is research and knowledge translation. Third is clinical and community care. And the 4th pillar is leadership and advocacy. So in rethinking those pillars, we wanted to make sure that they were all complementary, and that we would be working on each of those intensely within the organization. Not sure why my little button. Okay, so just the background. I think all of you on the call are pretty much aware of what psychosocial oncology is, but if we're thinking about the key words, it's really the social, the practical, the psychological, spiritual, and functional physical, which sometimes is left out of the definition of psychosocial oncology, but it's really important, and quality of life, and all these impacts on cancer. So you've heard, I'm sure, the words person-centered, and just as a à côté, we know how the field of cancer care has evolved. So if we think about the 1960s, people were just becoming aware of how cancer was impacting people's well-being, psychological well-being. So that's when people started studying anxiety, depression, and maybe more of a biomedical aspect of the impact of cancer. And then we moved on to look at social and situational factors that were affecting people's experience with cancer. And then we broaden it even more to talk about psychosocial oncology. And once we had a body of literature, both clinical observations and research, that really documented the multiple impacts that cancer can have on people, we started saying, well, once we know that, then how do we make sure that we address those needs according to people's individual situation? And then we moved even further, more recently, with saying we know the impact of cancer is multifaceted. And now that we know how people react, and now that we know that there's so many different individual responses to cancer, and there's so many contextual factors that affect people's experience with cancer, we need to be thinking about co-design, meaning anyone affected by cancer should have a say in terms of not only the interventions that they may be getting, but even the healthcare system, how the healthcare system is designed to really address those needs and be, like we said, person-centered rather than institutionally centered. So we've made great strides, as we all know, across this trajectory. Again, words matter. We've been called upon to ease off on the notion of cancer prevention, because they were saying this is kind of blaming the victim, and think about risk reduction, because someone may have a healthy lifestyle, may do everything right, but he still may get cancer. So prevention is part of risk reduction, but there is a consensus that we should be using the word risk reduction. So in terms of psychosocial oncology, it's really across the cancer trajectory. Again, people don't like to call this a journey. Patients are telling us if they want to undertake a journey, they're going to go on a trip. They're not going to go on a trip with cancer, in the sense that this is more of a trajectory than a journey. So here are all the facets of that trajectory, from risk reduction, screening, diagnosis, treatment, potential recurrence, survivorship, end of life, and bereavement. So what we've been able to see with the science of psychosocial oncology is that each of those stages has particular characteristics that are evolving, and that people's needs and preferences changes as this trajectory unfolds. And so as healthcare providers, as researchers, we have to be very conscious of the fact that people's experience and needs and preference will evolve, will change over time. And so we need to regularly assess how this is changing. And a great breakthrough was through patient reported outcomes. And this movement of patient reported outcomes it's been really ongoing and strong. So as I mentioned before, the strategic plan that CAPO undertook in 2021 included these 4 pillars. And what we made sure of is that we would integrate the patient and family voice in those pillars. We would pay specific attention to equity, diversity, and inclusion. And like many organizations, we are also focusing on increasing membership and capacity building by recruiting young members to either the board, or having student and patient and caregiver involvement in all levels of decisions within the organization. So if we focus particularly on psychosocial oncology advocacy, I think we all converge to say that, especially post pandemic, that we have to have enhanced access to psychosocial oncology support for all. As you know, there's been a significant increase in demand for supportive care or supportive services, and wait lists have grown exponentially. So how do we work towards enhancing access to that support that patient and others need so badly? The second priority for advocacy is really to fostering collaboration so that organizations that have a volet of advocacy don't work in silo, but actually come together to identify common advocacy priorities, but also some that are really coloring the organization in terms of priorities. So we should have both some priority that are really inherent to the organization and some priorities that are common. And once we come together, we should really be facilitating networking through exchange of ideas and obviously concrete actions. So people often ask, what is patient advocacy, or what are the key attributes that would make advocacy a real, genuine enterprise? And so here are some, the literature has some definition of what these attributes would be. So here I put a few: safeguarding what? Well, it could be making sure that we guard patient autonomy. We also safeguard patients against medical errors or care-related errors. Apprising would be to make sure that there is information that is fluid and that's flowing across the trajectory, so that everyone involved remain on top of the information that is really important in psychosocial oncology care. Valuing, which would mean maintaining, protecting. And what do you protect when you're advocating on behalf of patients and caregivers? Well, privacy. You may be valuing beliefs, preferences, as I gave examples. And when we think of preferences, the literature is really, really now rich in terms of saying people have clear preferences when it comes to wanting or not wanting information about cancer, their own cancer or the cancer of a loved one. They also have very clear preferences when it comes to being involved in treatment decision-making. We can't assume that everyone wants to be involved, but we should be asking the question, because we know that some want a very active role, others want a passive role, and others want collaborative roles. And that's the work of Leslie Degner, who has really documented those three different preferences when it comes to being involved in care. So, and there are many other, what is it for patients to be known by the cancer care team? We also have literature on that, what it means to feel welcome into a cancer care setting. So there's really rich psychosocial oncology work being published. And I think that made us much more aware of valuing the patient or the family perspective. Mediating is a very important role in advocacy, where we make sure that there is fluidity across patient, family, healthcare providers, and cancer care systems. So how do you mediate those different systems, and how do you make sure that there's free flowing of information? And the last feature is championing. So how do you promote, how do you confront practices that may be detrimental? How do you address inequities? And how do you really work towards social justice? So just as a background here, our advocacy committee is multidisciplinary, involves patients, family, and student representation. Samara Atiye was very proactive in this and is still very proactive in this role. So here I've listed the names of the chair and co-chair and who's involved. And what kind of discipline or the nature of patient involvement or caregiver involvement. And we're still working really hard to increase representation. We really do want to have a more diverse backgrounds, and so we're really proactively doing this as we speak. So specifically, the Advocacy Committee seeks to do at least 4 things. The first is to advise and assist in the development and implementation of advocacy initiative. And I think this talk today is a good example of wanting to do this and of getting the word out there that we're here to talk about it, to collaborate, and to move the agenda further. Explore and implement communication strategies, so webinars, keynotes at conferences, international representation in some advocacy group like Inspired to Live in the Netherlands or the World Campus. And we also need to be developing new communication channels so that we really reach out to those that are most likely to really make a significant contribution to advocacy. And so the partnering is really identifying multi-layered stakeholders, and so that we really hear multiple voices, and that we also partner with advocacy groups that are making a difference. So we've been asked as a committee to make sure that our objectives would be SMART, and SMART meaning specific, measurable, attainable, relevant, and time-based. So there is this push to be sure that we are operationalizing what we are set to propose. So the first one is to create a repository of Canadian psychosocial oncology advocacy organization, and I'll give more details to this work as I move through this presentation. And I hope to have a discussion at the end so that anyone that think of maybe underrepresented advocacy organization across Canada can speak up and let us know. I've mentioned recruiting new advocacy community members. That's also a priority, and develop channels for easy access and transfer advocacy-related knowledge, advocacy-related evidence, some of ongoing activities, and engaging the community and other relevant stakeholders. So these steps are identified here. The first, to create a repository. So what we've started is to really collect information about those organizations that are focusing on psychosocial oncology advocacy. And so we're in the process of refining that list and then co-identifying psychosocial oncology advocacy issues. That will be a big one. And then the third step would be to consolidate a national agenda. So having action items that are clear, co-create this agenda, and seek external endorsement so that we are all working towards similar goals, and periodically assess how well we're doing. So just to give a sense of how this search strategy was implemented so that we could identify psychosocial oncology advocacy organizations. So here you see some of the keywords that we used and some of the databases that we also identified, but we had to go beyond Medline and Ovid database and go with the great literature, but also, social media platforms, Google, the Canadian Cancer Society, Community Service Locator Tool, and internal feedback. So through this process, we were able to, in the more traditional way, through the database, identify 128 organizations, and then 68 through the great literature or word of mouth. So to be included in this list, there had to be an explicit psychosocial oncology advocacy in their mission. And there had to be also very tangible activities that were being carried out, either at the political, social, economic, or cultural levels. We decided to exclude any federal and provincial cancer care organization that had a general focus, so that it was generally focused towards cancer, but with no explicit psychosocial oncology advocacy agenda. And also we had to exclude cancer care programs that were providing services, but did not have advocacy action in their offer of services. So here a summary of what that looked like. If you look at the 128 and 68, that was a total of 196, but there were many duplicates. And so we excluded if they were duplicates or not directly related to psychosocial oncology advocacy. So we ended up with 88 organizations. And through a third screening, with excluding some that didn't have a specific focus, we had 74. Now, the 74 organization were part of a survey where, and it is the first wave of survey, so it is a short survey that looks at what is the status of this organization in terms of a nonprofit or charitable organization. What kind of psychosocial oncology advocacy activities do they carry out? And what are their affiliations? So through this process, we excluded 4 more, ended up with 70. And of those 70, 35 were able to confirm their PSO advocacy, and 35 were still waiting for them to complete the survey. So what we also found was that those advocacy organizations were mostly based in Ontario, so 40 were there, and Quebec at 12, and then it was across the country. Now, just to comment on that, it doesn't mean that because they're mostly based in Ontario that their outreach is Ontario-based. So we're just looking at geographically, where are they? And then obviously, as we move forward, we'll be able to further distinguish their reach and the extent of their reach in terms of advocacy. So when we asked about status, and I must say here of those 70 organizations, 35 answered. So here we see that the status, there was some organization that said they were nonprofit or charity, but upon further research, there should only be one or the other. So we'll further identify with them, are they a nonprofit or charity? And then it goes to governmental, non-governmental. Anyway, you can see that the bulk is nonprofit or charity. When we asked about what are the main psychosocial oncology advocacy activities, the top one that came up was that they were supporting person-centered psychosocial care for patient and caregivers. So they were really advocating for access to information and services. Raising public awareness about cancer supportive needs was the second most important. The third was liaising with representatives of various cancer agencies on any psychosocial oncology issue. Fourth was informing legislators. So again, making sure that legislators were aware of the importance of access to psychosocial oncology information and access to psychosocial oncology services. Lobbying came next, and lobbying in terms of sensitizing government officials about certain policy and impact on patient and caregiver well-being. Less frequent, we're working with government to establish psychosocial oncology policies and designing and implementing research. There were others, and we'd be happy to share what these others were if you're interested. So here are just some examples of psychosocial oncology advocacy focus groups at the national level. We have the Canadian Cancer Society, we have the Canadian Association of Nurses in Oncology, we have the Canadian Partnership Against Cancer, and nicely today, this group of the Canadian Cancer Survivorship Research Consortium. So this is advocacy at the national level. At the provincial level, we have examples here of Coalition Priorité Cancer in Québec, which is very active, OPAC, One Ball, Kids Cancer Care, and community, we have Hope and Cope, we have Childhood Cancer. So these are just examples. It's not meant to say that these are the most important ones, but I think here what will be the challenge next is to say, okay, if there is national outreach of these organizations, are they more active in certain regions or less active, or which of those provinces or territories engage with the national organization when it comes to advocacy? And what are the features of more provincially based advocacy groups? Do they tend to be more successful in implementing advocacy priorities just because of the fact that health relates to provincial jurisdiction? So it's changed more likely at the provincial level. And so it would be very interesting to see if there is a difference in terms of advocacy outcomes if you're provincial as opposed to national. And then community-based, again, what are the strengths of doing advocacy at the community level? What are some of the challenges that may be faced by community-based organization when it comes to advocacy? And how is this partnership across community, provincial, and national? What does that look like? Is it purposefully planned, or is it more opportunistic in terms of connecting at conferences or at gathering and saying, hey, we're doing this, how about we join forces? So I think it'll be very interesting to survey these groups and say, you know, how do you come about collaborating when it comes to advocacy for certain issues that concern the local level, provincial level, and national? So in terms of next steps, I think that is clear that we're still working on refining the repository of those advocacy organizations. We're updating our data bank as the information comes in. We have to identify some of the leaders in those organizations and directly contact them, because one thing that we've noticed through the pandemic is there's less presence in offices of these organizations and more online presence. So how do we make sure that we contact the key stakeholders and that we get them engaged in our survey? So the second priority is definitely to identify advocacy priorities and gaps. So this is going to be done through a larger survey that we're in the process of developing. And, you know, what works well will be part of the survey. We want to know what they've been successful in, what are priorities that these organizations share with other organizations, and what are the gaps that exist also. And last, post larger survey, we will consolidate this agenda in constant interaction with other advocacy groups to make sure that we identify key action items that CAPO will spearhead for 2023. So there's this cycle of advocacy that comes with you know, going through the loop of identifying common psychosocial oncology advocacy, but contextualizing it and making sure that we get feedback on those common priorities. The creation of a shared national agenda is definitely top priority for us. We need to be seeking endorsement for provincial and national bodies, but I would add also from community organizations that have traditionally been very involved in advocacy. And as we implement this agenda and as we reach out for other stakeholders to join in the agenda, we want to evaluate systematically what are the outcomes of sharing and working on a shared agenda, and what are some of the gains and what are some of the challenges that we need to address very quickly so that we can redirect our efforts to always ensure that we optimize outcomes. This is very much what we're working towards. So I'd like to acknowledge CAPO, who has been an amazing supporter of this work, Hope & Co, who is the community organization that's been also supportive, my team, the Loiza Lab team, and McGill University. And I'm very happy to leave some time for discussion. As this is advocacy, we really want to hear from people and see what are some of the priorities they're working on. Are there some advocacy organizations that are not well known and you would like to bring to our attention? So there is an email, support@capo.ca. And in closing, I would also like to stress that as we move from person-centered care, which tend to be responding to people's needs, to co-developing or co-designing cancer care, CAPO has chosen as its main theme for the conference in June 20th to June 22nd in Montreal in 2023, its main theme will be about co-designing innovation initiative with users to ensure that they respond to their needs. So we're very pleased, and hopefully you can all join us at the conference and present on maybe your own work on either advocacy or co-design. So thank you for your attention.